Now we request our guest orator, Dr. Mohammed Kunju sir, to deliver Prof.A.H.Einhorn Endowment Oration on the topic Treatable Pediatric Neurological Conditions, Decades of Progress.
Okay, good morning. First of all, I must thank the Masonic Medical Center for inviting me to deliver this prestigious oration. I am indeed very happy that I am delivering this oration. And again, Dr. Ramaswamy's dedication to his mentor, which has to be learned by our youngsters, because nowadays, because I am teaching a lot of students, but many are recognized, because here also in the morning, one of my students came here, Dr. Sudhakar. He is, I think some of you may be knowing him. So he was my pediatric neurology fellow in SLA hospital. So such things are there. But again, many may not be recognizing us after they pass out from our institution. So I think definitely remembering their own mentors is a very exceptional thing. And I thank Dr. John Mathari, Dr. Karthikeyan, and all others for inviting me here. And I must start my oration by giving Trivandrum to Dr. Anandam. Because when I joined my pediatrics as a DCA student in Trivandrum Medical College way back in 1983, she was there, and we were working together till 2000. Then she retired. And since then, I was in charge of the pediatric neurology department of Trivandrum Medical College. From a single person unit, we were able to make a separate department with physiotherapists, speech therapists, such specialists also there in our department. But we all know that from early days onwards, the pediatric neurology was considered as a sort of a philately, where you'll be collecting the cases, making a diagnosis, but leaving it like that. So specific diagnoses were low. Either it may be a seizure disorder, or all cases will be cerebral palsy. And many times it will be syndromic diagnosis. For example, you just make a diagnosis of Guillain-Barré syndrome, or you make a diagnosis of polio. But many cases of polio, we have, myself and Dr. Anandam has visited the isolation ward, and we have made a diagnosis of neuroblastoma out of polio. So by examination, so that is the importance. So, and most of the cases we were giving only symptomatic treatment. And pain, you know, that it is a very important problem in pediatrics, and pediatric neurology is never given any importance. And you do all the procedures just by giving pain to the children. We never make it analgesic procedure. So we can say that we were telling that pediatric neurology was just an armchair practice when we started the pediatric neurology. But as of now in 2024, we know that many disorders, because when I started my career as a pediatric neurologist in 1990, I must say that, because I started active practice after completing my DM neurology. My colleagues in pediatrics asked me, what are you going to do with pediatric neurology? There are no treatable conditions. But now we have a lot of things to offer. And we know that even for the treatment of cerebral palsy, there are specific treatments are there. And we have various neurometabolic disorders which are treatable. And epilepsy treatment, we know that it has gone into a personalized therapeutic approach, that is the precision medicine. So new drugs are there for various conditions like epilepsy, migraine. You have genetic treatment, and even simple vitamin is used as a therapeutics in many of the neurological disorders. And knowing about the neurodevelopmental advances has also helped us in helping the treatment. And I must say that there is one more thing that has gone just out. That is the preventive neurology also is very, very important, where we can offer early diagnosis and treatment in many disorders. So early diagnosis, early intervention, and the specific treatment is our realm now. So starting with some of the case scenarios. See, there were very evident diagnosis early when a child, so for example, in early 80s or 90s, when such a child is presenting with fever and abnormal movements with the Parkinsonism features or dystonia or dyskinesia, the diagnosis was Japanese encephalitis, especially when with the setting of our Kutanad area or Alapi region, where the duck rearing is a practice, or in those areas where pig are there. So with the triad of this an extrapyramidal encephalitis with a typical MRI pattern of involvement of thalamic involvement with epidemiological support, we could make a diagnosis of Japanese encephalitis, and which was supported by the diagnosis of serum IgM, diagnosis of Japanese encephalitis. And this fantasy. And many times people used to tell that there is no treatment for Japanese encephalitis. But I must say that all of you are treating using modern medicine as your practice. Don't use the term not treatable condition, because we all want a cure like pneumococcal pneumonia is treated by penicillin earlier, and nowadays it's a Traxol. So you want such a cure shot for everything. But when you are managing a dengue, we say that there is no treatment for dengue. And but the alternative people will come with papaya juice and then that is the treatment. But what are you doing? You are from the day one onwards, you are monitoring the patient. You are finding out all the parameters that are coming down. Patient is managed with fluid management, their shock management, and other management, and the patient recovers and they recovers completely. So you are treating and you are curing the patient, but still you will say that we are not treating the patient. But so you have the armamentarium with you, with your correct monitoring, you are able to manage it. Similarly for Japanese encephalitis also, they have initially when they come with the raised tension, you manage the raised tension in a scientific manner. You manage other complications and ultimately the patient recovers. If they come to the hospital, they will recover. If they don't come to the hospital, they will die. So you are treating, but still you will say that you don't have any treatment. And that is being perpetuated everywhere. And people go to Ayurveda, Unani, ultimately they get the courage for the treatment. So that is what is happening. So here onwards, to all my colleagues, I tell them that you have a treatment for most of the conditions, you are supporting them and you are trying to cure those patients. And secondly, again, a diagnosis must be offered to the patient. Because again, a Japanese encephalitis like patient comes. We will say that the patient is having encephalitis. We know that. But we will persuade a diagnostic testing to see whether it is an enterovirus, whether it is a Nipah virus or a Japanese encephalitis like that. They will tell them we haven't found out anything. But already the condition is that it is encephalitis and the treatment is same. So, but we will give an idea to the bystanders that you haven't had a diagnosis, and they will always tell you they don't have a diagnosis. But while we are looking for tuberculous meningitis, which you should not be missing. That is why we are continuing with the investigation. But your diagnosis is Japanese, it's encephalitis. That is enough for a lay person. So you give that diagnosis and tell them that it is a diagnosis, but you are trying to identify other conditions. That is all. Anyway, so. And once we were all having that sort of a diagnosis earlier, but now we know that a child is coming in this manner with self-muttering himself, with the behavioral changes. And initially it was seen by the psychiatrists, they made a diagnosis of a childhood schizophrenia. He is responding. So people thought that it must be only a psychiatric manifestation. But so behavioral changes, hallucinations, etc. But while the patient was in the psychiatry ward, we can see that he has developed this sort of phenomena, which is very characteristic of a fatiobrachial, see that form, that is the fatiobrachial dystonic seizure. So a child who is presenting with the febrile illness, with the behavioral changes and fatiobrachial dystonic seizures, what will be your diagnosis? It will be an autoimmune encephalitis nowadays. So earlier, when such presentations were, we will be looking for a Japanese encephalitis. Even now also, in a epidemic area, you think of that also, or a West Nile virus encephalitis. And so it was diagnosed only, the condition was diagnosed only in 2000 or identified in 2007 by Dr. Joseph Dunmore. Then we were all seeing those cases as subacute encephalopathy, and we were just treating them with various methods of treatment. And now we know that by the identification of various antibodies, we can able to make a diagnosis. We can able to treat them in a scientific manner. And so we all know that in pediatric age group, this NMDA receptor, NMDA receptor antibody encephalitis is the commonest one. Earlier, in 1 year itself, 13 cases of autoimmune encephalitis where we have stated, you can see that we start with the methylprednisolone and IVIG, and then we may go for other immune modulator treatment. Then we can see that those patients who do not respond will go for the second line treatment with rituximab, cyclophosphamide, and they will continue with the mycophenolate mofetil. But nowadays, we are seeing many cases which are not responding to this second line drug also. There you may go for tocilizumab. And recently, for one patient, is gave bortezomib, where again you know that it is by subcutaneous injections of 1.3 milligram per meter square of bortezomib with 20 milligram dexamethasone twice weekly for 2 weeks. That is the day 1, 4, 8, and 11 was followed by a 10-day rest. And our patient actually, till then, almost 3 months of the onset, was not showing any improvement, super aggressive movements. But he started showing dramatic improvement, and now he is able to walk without much movement. So at that time, we found that there was a seasonal cluster. You can see there. See the January, February time, there was a cluster. Then again in the month, rainy season, again May, June, there was a seasonal dispersion. So we thought that there may be a relationship with the viral infections also. And this side, here again, see, whenever a child presents with sort of a orofacial, you look at that orofacial movements, abnormal movements, always think of her. She had only a mild febrile seizure-like presentation initially, but later this orofacial dyskinesia. And she was given dosages of IVIG, methylprednisolone. And after 1.5 months, she has improved, but still you can see that her movements are there. But definitely she had mucus, that was a major thing. That is why I just recorded her nursery rhyme. So there you know that it is secondary to NMDA receptor antibodies, and you treat accordingly. But if an older child comes with again such a problem, there you can see that again the abnormal movements on the, especially choreothetic movements or the facial dyskinesia, and when the hand movement are also there. Again, just like the conditions which I have mentioned earlier, faciobrachial dystonic seizures. What will you look for in such children? Yes, very good, excellent. And so this is the one which we have removed from her. Initially she responded, she went back, and then the parents started telling that she is having an amenorrhea. So her ultrasound revealed this teratoma of the ovary, and you can see that we have removed the ovary and she has recovered. So the triad of NMDA receptor encephalitis can be a behavioral or psychiatric manifestations. Usually they will be having a fluctuating fever with abnormal movements and extrapyramidal manifestations. You think of a NMDA receptor antibody encephalitis. And so you continue with the treatment in a stepwise manner. So that is the, but other infections, all of you know the management, and you have in Kerala, we are pursuing with the diagnosis of various other encephalitis, because in KIMS itself we have reported Zika virus infections, and all of you are aware of the saga of Nipah virus. Even recently also we had a small epidemic. Now coming to the most important disease of neurology, that is epilepsy. Here again, one point I always tell the students, we identify the mimics. Even in a comprehensive epilepsy center, because I am I always was connected with the Sri Trivandrum Institute because when I was doing my DM, even though I did my DM from Medical College Trivandrum, because of proximity and relationship with the Sri Trivandrum, I was always connected with them. And even there also, because when we take 100 diagnosed epilepsy cases who was getting treatment for with anti-epileptic drugs, 30 patients may be getting treatment for non-epileptic events. That you must remember. So each time when you see an epilepsy patient, think for non-epileptic event, because when they come with a recurrence, they will tell us that she had or he had another attack. They just tell you that attack, but then you have to ask them, how was it? Then they will say that just like the previous one. So you ask them to describe it, who has seen it, or if they have a video. Nowadays you can ask them to record it and bring it, so that you can see what is happening during many times maybe a pseudo seizure. It may be a breath holding spell, or a child might have had an injury to the head, so that has led to the reflex anoxic seizure. So that is not epileptic seizure. They will get seizure, but it is not epileptic seizure. You have to, and by giving anticonvulsants, you can't treat that, because you have to avoid that situation when precipitate the attacks. That is more important. Okay. So, and that is the one end. But now the other end, as I have told you, you have a lot of precision treatment. Dr. Maniyasa will be presenting that aspect because he is talking on genetic syndromes or genetic role of genetic disorders in pediatric neurology. But these 10 illnesses that we should not be forgetting. Actually, I have taken from one big book on metabolic epilepsies. But the same thing is given in Nelson Pediatrics also. So we all know about the pyridoxine-dependent epilepsy, where again pyridoxal phosphate, if pyridoxine is not giving relief, you give pyridoxal phosphate. You know that pyridoxal phosphate itself it is available, or different combinations are available, where again pyridoxal phosphate can be given. Or again, all of you know about folinic usage of folinic acid also can be given. And then glucose transporter 1 deficiency, where again treatment is by ketogenic diet and hyperinsulinism amonemia. So again you give a specific treatment for that. And the developmental delay, epilepsy and neonatal diabetes. There again the diabetes treatment is not by insulin but by metformin. So by that you can treat it. Then hyperexpectic syndrome, where a glycine receptor mutation, whereby simply giving long clonazepam, we can treat it. And you all of you know about the Viginamo techniques, where you just flush the child when this happens. Okay. And then the creatine synthesis disorder, serine biosynthesis defects, biotinase deficiency, cerebral folate deficiency, and biofilm synthesis, that is the neurotransmitter disorders, where by giving either a dopaminergic dopamine or going for a tetrahydrobiopterin, septopterin, we can manage these patients. And this side, which I have seen very again years back, maybe in again early 90s, the typical feature is a fragmentary myoclonus. See the fragmentary myoclonus. It is fragmentary myoclonus. But look at the child. Child has see the alopecia there. See alopecia, and if you look at the skin, see the dermatosis. See the peeling of the skin, and again you can see that the peeling over the fingers. So now you have the diagnosis, isn't it? A child who has presented with myoclonic seizures and skin manifestations, alopecia. What do you think of? Yes, biotinase deficiency. And we were able to do a biotinase estimation at that time, and biotinase level was low. Normal value was 4.5 to 9, but it is only 3 nanomole per minute per ml. So a biotin at the rate of 10 milligram was given, and child has improved. Similarly, suppose when you are asking for an MRI, ask for an MRS, because many times again MRS they will not give a report. So you do an MRS, and here you see there are only 2 peaks there. Normally, what should be there? See, there are different peaks. Again, easily you can remember that, because I took at least more than 2-3 years to understand the MRS, because I was attending the Sri Chitra radiology sessions. They will come and tell about various MRS markers, but they will not make it simplified. So I didn't understand anything. But later only I understand this is a very simple thing. There 3 peaks are there. One at see the 1.2, where you have the lipid lactate peak. That is ppm. 1.2, that is a lipid lactate peak. And at 2.2 or 2, it is the NAA peak. And 3.2, it is choline creatinine peak. That's all. So you look at the 1.2, 2.2, 3.2. And one more creatinine peak is also there. And you see there is a rising amplitude from left hand to the right hand. So you can use the term Hunter's angle for this. And here what you see, the between in this one is missing. That is the choline creatinine. The only choline is here. Both the creatinine peaks are not there. So you have the diagnosis. So it is a cerebral, it is a creatine deficiency disorder. So you give a creatine. You know that nowadays in all the protein stores, those gym people are visiting, it is available. So ask them to buy from those sold shops and give creatine. So the patient will improve. And we have a lot of anticonvulsants. We know that starting from our phenytoin and sodium valproate. Then from at the end of from the beginning of 90s, 93 onwards, newer drugs are coming, and finally in our market cannabidiol has come. Before that, brivaracetam has come. So monthly basis, newer anticonvulsants are coming, but still the treatment, actually the effect is almost like the previous. But we have a lot of choices to treat these epilepsies. And as I have mentioned, the specific treatment, when you are doing a genetic study and you identify a specific mutation, for example, SCN1A mutation, it may be a Dravet syndrome, where you give tridipendol, or the currently newer drug, which I didn't add there, is fenfluramine, is the newer drug approved for Dravet syndrome. And again, if another mutation like green2, if it is SCN2, here you see SCN1A mutation, you will avoid sodium channel blockers. But if it is SCN2, then we will treat with sodium channel blockers like phenytoin. And if it is a green 2A mutation, as it may be seen in a Landau-Kleffner syndrome, or continuous spike and wave inslavously, or nowadays it is called as ESWAS, where the treatment either would be with memantine or dextromethorphan. So dextromethorphan may be useful. So there are a lot of mutations. Again, I think we'll be talking, and you can read about. I'm just giving an idea about the development in pediatric neurology. So similarly, nowadays we know that again I told you that I am very much related to Sri Chitra. So there, along with our own patients, we have a comprehensive program. And in epilepsy, you make a diagnosis, lesional epilepsies, and so you can see the various types of lesions we have identified. Among them, 73.3 is mesial temporal sclerosis, but other ganglioglioma, astrocytomas, carbonomas, all of these lesional epilepsies. And this is one older case where we thought of as the medial temporal sclerosis. But you can see that some bulging is also there. It was a case of ganglioglioma, and it was removed. Similarly, when you are going for an MRI or a CT scan earlier, you may think that this CT scan may come as a normal report. But if you look carefully, you can see that there is some density difference there. So there is a focal variation is there. So MRI is revealing a focal abnormality, hyperintensity is there. You will be definitely see routine T1 weighted image. Again, if you look carefully, you can identify, because when you are reading an imaging, always look for a symmetry. That is one thing. Then look for whether there is any different dark areas or white areas. That is in all images, just X-ray or echo or MRI or a CT scan. Look for any black or white areas. So here also you are seeing some black area here. So see higher resolution MRI reveals hyperintensity in this region. So it was resected, and you can see that biopsy finding. So it was a focal cortical dysplasia, Taylor balloon type. Similarly, another 40-year-old female with intractable seizure. Where again you can see the very small lesion there. See there, see this one, and that also being removed. That is the post-operative imaging, but that was a non-balloon cell type of cortical dysplasia. So look for a lesion and you pursue for a surgical management. But when you are telling about all these things, we must know that in our country, even if you prescribe anticonvulsants to a child or an adult, 30% will not take treatment. They will come and tell you that, sir, my epilepsy is not there. Maybe you may be seeing after 3 years. That is the natural history. Dr. Mani of Bangalore also has done the study. 30% will not have much recurrence. So they will not get cured otherwise also. So you have to give an idea about the epilepsy treatment programs available and when to treat. So you have to go to the community and give epilepsy awareness talk. So even nowadays we know that people use a key in our place to stop. Even an educated teacher will give immediately a key to a SSLC student who is conversing in her class. Or they will pour water into the mouth, thinking that child is going to die, and at least I will give water in the edge. And so like that. So we have made a short film on epilepsy. Actually, the serial actors, Malayalam serial actors also helped us to act in that film. It is there in the YouTube. Now it has almost 4 lakhs views there. Now we know that migraine in pediatrics. Again, my neurosurgery colleagues used to ask me, can children get migraine? You know that, yes, even a 1-year-old child can get migraine. So, but only thing is that you must identify the etiology, the clinical manifestations of migraine. And you can, here again, you can go for a 3-pronged management, where again you go for a comprehensive evaluation. There again, I told you that you don't have to do a detailed neurological examination. So, just when you are seeing the patient, your child is sitting in front of you. There is child, mother feels that she has vomiting also. Then just in front of the child, you just wiggle your hand and ask the child, are you seeing my fingers moving? If she says that I am seeing both the fingers moving, means that there is no bitemporal hemianopia. Most of the cases in a child with a headache, if it is going to be a problematic condition, say it can be a craniopharyngioma or a pituitary adenoma, where again the visual field abnormal will be a visual field bitemporal hemianopia. You don't have to do that. The field testing as being taught by our teachers. You sit in front, do all these things, but this is enough. So bitemporal hemianopia. Even in a homonymous hemianopia, they will say that I am not seeing on one side. Then you do the proper testing to see the bilateral. So if it is there, and as far as possible, I think you must do a fundus examination, which is very easy. Nowadays, sometimes, because we all, I have seen people referring to the ophthalmologist for seeing the fundus. Then you try to identify the headache types, whether it is a primary headache or a secondary headache. If it is a primary headache, again it can be 3 types, because it is migraine, tension headache or headache, and earlier we used the term cluster headache, and now it is a trigeminal autonomic cephalalgia is the terminology used for that. And then you treat. For treatment also there are 3-pronged attacks. So where the 3 types of headaches are primary headache, secondary headache, and facial pain are there in adults. But many facial symptoms are not there in children. And then coming to the 3 types of headache, as I told you, it is a migraine, tension type of headache, or a cluster type of headache, nowadays called as a trigeminal autonomic cephalalgia. And 3 modalities of treatment are there. Where acute treatment. Again, when headache is there, ask them to give a medicine so that the patient will get relief. They don't have to lose their school days. And then go for the preventive treatment, because if the attacks are more than 2 headaches per month, give a preventive treatment. And definitely they will require a bio-behavioral treatment, changing their lifestyle, because nowadays adolescents, even not adolescents, all the children will be seeing mobile even during night, sleeping only by 2 o'clock and getting up by 10 o'clock, like that, And so the three types of acute treatment are NSAID, antiemetics, and triptans. And the three types of chronic treatment are beta blockers, amitriptyline, and anti-epileptics like topirol. And coming to the treatment armamentarium, now we know that the CGRP drugs are available, CGRP modulators, where CGRP antibodies or CGRP antagonists are available, different for acute treatment as well as for preventive treatment. Nowadays, the trials are going on in children also. And the latest entry, I think some of you might have already heard by the representatives who has brought in ditans, because all of nowadays we are all aware of triptans. Now ditans are come. Ditans, the advantage is that it is a serotonin 5-HT1F receptor agonist, which can be used in the acute treatment, and it doesn't have any action at the vascular level. So it doesn't produce a vasoconstriction. So it is safe even in those patients who are having some cardiac problem also. So ditans, various, so it is the last minute tag. Various trade names have come now. Many neurological companies have started marketing it in India also for acute. This is the foreign trade name. I didn't get the Indian trade name here. And but again in a migraine case, you have to do an examination, and if there is an ophthalmoplegia like this, definitely we will go for an MRI. And here you can see that ophthalmoplegia is there, ptosis is there. So the MRI, in this case, you can see that there is a hyperintensity involving the pericavernous sinus area, and which is enhancing with the contrast. See here, plain contrast. And so this may be a Tolosa-Hunt syndrome, and which will respond very nicely to steroid. So you identify, you give oral steroid or methylprednisolone, and the patient will completely improve. And then coming to the various neurometabolic disorders, I think again I am not going to the details, but nowadays pediatric neurology, especially those pediatric neurology who are passing out from the various centers, academic centers, they are more well versed with the neurometabolic disorders. But neurological aspects, I am not happy with their knowledge, but the neurometabolic, they are very much well versed, because it is an investigation based. So you do a lot of investigations and ultimately you get a diagnosis. But clinically also they can have very severe manifestations like this, with the albinotic manifestations, mental retardation, seizures, etc. And earlier, I set up a neurochemistry lab in our department initially just for doing a urine testing like this with a urine ferrichloride test, which will give an emerald green color for PKU, for a greenish brown color for histidinemia, and navy blue color for maple syrup urine disease, etc. But nowadays we don't do these things, because we can directly ask for a TMS or a GCMS, and again enzyme estimations, and finally we will go for a gene diagnosis by doing a clinical exome sequence, because most of the neurometabolic disorders, they are monogenic disorders. So you go for a clinical exome or a whole exome sequencing or a mitochondrial gene sequencing, and you can make a diagnosis. If you have made a diagnosis earlier, even now also we offer dietary modifications, where again phenyl free, and you know that Meta Nutrition, they provide almost all metabolic diet for various conditions. And the current the treatment modality that is come for phenylketonuria is large neutral amino acids and glycomacropeptides. Where again, it is this large neutral amino acids and mix of tyrosine, tryptophan, methionine, valine, isoleucine, etc. They compete with the phenylalanine absorption, so that the absorption of the phenylalanine will be less, and the various amino acid deficiency also will not be there. So that way, the management of clinical today will be better. And from early years onwards, we are making diagnosis of this dengue hair disease. Here again, I just kept it because when we were discussing the pediatric neurology cases, especially when there is a DLA diseases, there invariably the diagnosis of dengue hair disease will come from our teachers, and they will immediately say that there is no king the hair, so you can exclude it, but you can't. Earlier, I was also looking for the king the hair. But later on, I didn't get the microscopic picture of this one. You can detect the kinking only by looking at the microscope. The hair will be just a blonde hair and maybe slightly friable that side. Yes, so that is kinking will be seen. That means the pile of total will be seen. So I pluck my hair and the child's hair and put under the microscope. You see the pilot tongue. So, or trichonexus nodosa will be seen. That is how we make a diagnosis. Okay. Remember that king the hair. So, suppose you can see a child with a king the hair, then think of a giant axonal neuropathy. That is the diagnosis. Okay. If you are seeing clinically a king the hair. Okay. So, there you prepare the copper histidinate. Because earlier our pharmacists in our department were preparing it, but nowadays we send them to Vellore only for they are giving treatment. This again a child who was diagnosed by CT scan way back in early 90s with the pigmentation and MRI finding showing this sort of the garlanding appearance. How do you manage it? So for that child you can't manage much, but if the child is having a sibling, young sibling, or they are planning to have a child, and if the child is happen to be a male fetus, then when they are delivered, immediately you offer a bone marrow transplantation. Even though this Lorenzo soil has come with a big bang, and the film also has done very well, but Lorenzo soil definitely does not give any cure for the patients with adreno. So that's a case of adrenoglucose dystrophy. Here you can see the posterior head region will be showing the hyperintensities. So bone marrow transplantation we can. And nowadays enzyme replacement therapy in many disorders which earlier when diagnosed will die. For example, this child, we made a diagnosis of a Pombe's disease at the age of 7 months. Now at the age of 10 years he is surviving. The child would have died at 1 year if we haven't offered myosine treatment at that time. So you can see that myosine treatment has given her full cure. Similarly, we are giving enzyme replacement therapy for a patient with MBS2, that is Hunter's disease. So again, he is around 18 years, just completed his 12th standard also. He has some skeletal problems, joint contractions, otherwise he is doing well. And MBS1 treatment. And again, recently we have started treatment for a Gaucher disease. So these are the enzymes that are available for enzyme replacement therapy. And another one which has come in the market is subliponase alpha for the neuronal ceroid lipofuscinosis type 2, which here you can see it's an intraventricular infusion. So that's the problem of the managing the blood-brain barrier, passing through the blood-brain barrier is so that was a case of Gaucher disease, where again you know that the substrate reduction therapy is possible. And this one diagnosed very early, but here it is an older patient where you can see the tendon sandoma. This was being removed by the surgeon repeatedly, but the patient came to me. I found that he has a sibling who was having a mental retardation as well as ataxia. So it was a case of cerebral xanthomatosis. Now we have treatment for that also. Right? How do you treat? You use cholic acid or a chenodeoxycholic as a combination, and thus the patient can improve. I think before concluding my talk, I think only 35 minutes over now, so I think I can take 10 more minutes. This because I have a timer here. It's just past 35 minutes. Okay, so I'll just go to the cerebral palsy, which I think again all of you may be aware that because for a pediatric neurologist, that is the main thrust. Where again you have this condition, that is diplegic cerebral palsy, definitely with a very good prognosis. So don't tell the parents that the child is burden to you, but they will definitely walk. They will have good meditations, and definitely they will be asset to the family. And the only thing is that they treat the this time. Again, you know that what is it? Yes. So choreothetoid cerebral palsy, where again nowadays such cases are rare, but still severe dyskinetic cerebral palsy you will be seeing, and see that dystonia there. And there you can treat it with tetrabenazine. You give the tetrabenazine 25 milligram, and this sort of a severe movement will come down. And they will have, because of that, orofacial dyskinesia, they may not be talking. But you give this, their speech also will improve. And remember that the dyskinesia cerebral palsy is coming down because of the treatment, structured management of jaundice by the newborn. But diplegia cases may be increasing because you know that even 600 gram or a 500 gram may be surviving. Because of that, the prematurity leading to diplegia is increasing, the other one is coming down. And once you make a diagnosis, because your aim in managing cerebral palsy, whenever asked to the students also, they start telling the treatment of spasticity. But it should start by the early diagnosis of cerebral palsy, because earlier people used to make a diagnosis of cerebral palsy by 2 years only. It was said like that. But now there is a leading article came up in JAMA where they are telling that you must start diagnosis as early as 6 months by doing the clinical assessment. So you can go for a early stimulation program, early intervention program. Here, so right stimulation at the right time in your grandma's method. You give a stimulation and the patient will improve. And again, the mother should be the therapist rather than sending them to different therapists. So, where see, by just the traditional carrying technique, we are asking the mother to keep the child astride so that the spasm, erector spasm will come down because carrying. And ask her to just do the movement, flexion extension movement in the dorsum of the foot so that TS spasm will be coming down. And then again the knee joint movement. There again you can reduce the hamstring spasm. Okay. And ask the patient to change the side, and then the other side also she is moving it. So that means the mother can regularly give therapy so that the spasticity will come down. And then again mention about the activities of daily life, because they may not be trained in feeding. A 3-year-old child also mother will be grueling the food, and they will look for any particle there, they will remove everything and pour it into the mouth. But as early as 6 months itself, they must be trained for normal feeding. You know that there will be difficulty feeding because of the tongue thrusting. But feed them properly so that, and then adaptations may be required. So that will help in improving all the activities of daily. That is what is called as occupational therapy. But again, tell the mother that these are the things that you have to do, and the mother will take care of that. So that the enabling the disabled would be your where always tell about the 4 E's, where the empowerment and giving them entertainment, education, and providing equal opportunities. That is very, very important. And but along with that, we have a lot of newer treatment modalities like backlog and pump. We have put in a few patients, but for cerebral palsy, it is not that useful. It may be useful in a traumatic spinal cord injury in an adult, but not that much useful in a pediatric patient. And we know that there are a lot of regional and local injections are being given. But nowadays, it is not nowadays because from 1998 onwards, we were using, even though I have put that slide as new, in 1998 onwards, that means almost 25 years or 26 years, we are using botulinum toxin for the management of cerebral palsy. So it is, you know, that it is acts by, it is a neuromuscular blocking drug by blocking the acetylcholine release. So it leads to a chemical denervation. And so the chemical denervation, so the nerve ending has gone. But within 3 to 6 months, a new neuron will sprout and a new neuromuscular junction will be produced. So this gap of chemical denervation we utilize, and you give by giving a botulinum toxin, we can manipulate that time for a physiotherapy and training, and they will improve. So that's what you do. Usually when there is a tender Achilles spasm is there, we assess it by doing a cardiac scale, that means acute movement R1 and then a forceful movement, so that you know that there is a window. It's not a fixed contraction. Similarly, the knee also do that. See here, initial movement only coming up to that, but then full force, see it is coming straight. That means we can give a botulinum toxin to the hamstrings here. The other one you give injection to the calf muscles. So similarly, so you give in a multi-level injections. So that if hamstring spasm is there, calf muscle spasm is there, adductor spasm is there. So you give injections to different muscle groups. And I have made it very simplified because people are telling in corporate hospital they will admit the patient and it will be done as a very big procedure. But it need not be. We can get the botulinum toxin nowadays because 2 vials will be we can purchase for 2 vials will be only 24,000 rupees. That means for 1 vial it is 12,000 only for 100 units. And so this time who has adductor spasm, so we give injection to the adductors. Or who has a crouch gait, here you give injection to the hamstrings. Or there is a toe walking, so you give injection to the calf muscles. And see, for simply what you do, you just sedate the patient and then what? So you keep the patient like this. Identify the 4 sides. You don't require an ultrasound or an EMG or localized. You identify the 4 sides. And see, initially the needle is punctured and you see the muscle, which is inside the muscle. And then already you have prepared dissolved botulinum toxin and you can inject, withdraw. Okay, so you have at the 4 sites. I'll show you that 4 sites. So these are the 4 sites where you give injection. You just clinically identify that and give dilute the botulinum toxin injection. That means for a 20 kg child, you can go up to 60 units per kg total injection. And for a site, see 3 units per kg per muscle can be given. What I do is take just 100 ml, 100 units of botulinum toxin, dissolve it in 4 ml or 8 ml saline, take it in 8 syringes, 0.5 ml is given in each side. So then 4 sides you give like that, other cap also you give. And this is what we have recently given injection, and you see the pre-injection. This is you can see that toe walking, child is not supporting himself. You can see that spasticity there. Because see, scissoring is there. And this child was given injection. And this is just after 2 months. See, now the child has the toe walking has gone. Child is using his heel walking is there. Some adductor spasm is there, but still you can see that difference how child is walking now. So definitely you can offer an ambulation by this sort of treatment. Okay, so along with that, during that window period, after the injection, you ask them to do the therapy in a very regular manner. And again, this orthosis, day orthosis and night splints can be used. This is one patient, again, you see that walking pre-injection. 6 weeks there is an increased pneumonia, but by 9 months you see the child is having a good posture. And just to tell a few points about neurodevelopmental treatment also, I'll just finish in 3 minutes. where again, you know that autism is diagnosed by impairment of socialization. Because when I ask my students, people are not aware what is, everybody knows about autism, but they don't know what is autism. This autism, you remember that, because just like socialism, communism, that means here autism means he is interested only in auto himself. That is why it is called as autism. So that means they will talk after Sunday, but they will talk, I want something, they will say, but they will not ask, do you want something? They will not ask like that. But when they start speaking like this, that is, I want food, parents will say that he is speaking, and they will not seek a medical help. So that means impairment in socialization is very much impairment in communication, and there will be a restricted repetitive behavior. So this is the triad. If it is there, then you make a diagnosis of that is RRB, restricted repetitive behavior. So remember that. And just like I told you that you can make a diagnosis of autism, cerebral palsy by 6 months itself. Nowadays, all the associations say that you make a diagnosis of autism by 3 years. But see, I make a diagnosis by, say, I am showing this video. Okay, what is the age?
9 months.
9 months?
3-4 months.
Yes, just 3 months. So it is not an exceptional case. This is what happens at 3 months of age. A child of 3 months of age, when you are talking to the child, they will respond, they will mutter, they will pucker their lips, and see that. So if that is there, you know that this child is going to be a normal child. Understand? But many times they may look at you when they'll be playing around there, and parents will think that child is, but always the child will be looking at a fan. They are more interested in objects than a human being. So see that if they are more interested in human being, then they are having to go to a normal child. And so actually I have kept some slides there, but it's not. Anyway, so look for that and make a diagnosis early. And I think regarding another situation is the stroke, where again the stroke, you know that you have to pursue for etiological conditions, where again nowadays you know that these cerebral arteriopathies are coming into a very big conditions. And this child who was having a herpes, varicella, herpes zoster, was having a stroke. So you know that the varicella has and the different vascular arteriopathies can lead to stroke. And in this case, I just tell you this child who had a recurrent hemiplegia. Initially, we are just thinking it as a routine stroke. But after the third attack only, we found that we usually look for any renal problems, you know, for a hypertension which lead to a stroke or embolic stroke. Here again, initially this CT angiography was reported as normal, but then we found that there's a right renal scarring and microaneurysm. And then the symptoms came, that is ankle joint pain. Just at 3 years of age, petechia of the skin, which manifested only after the third attack. And so that means I was always saying that vasculitis usually in children will be happening above the age of 6 years only, because most of the aspects we know, SLE, rheumatoid arthritis, all will occur in the. But nowadays you know that there are newer other vasculitis phenomena. This was a case of DADA2, adenosine deaminase deficiency. So that was detected, and so the mutation also was there, and so the treatment was given with anti-tumor necrosis factor 8. So identifying the etiology is very, very important, and always think differently also. I think this may be the last one. Okay, so what about this? What is your diagnosis? Stage of syndromes. Yes, cleft has actually happened later. It means the apparent clefting. But anyway, all of your diagnosis is stage over syndrome. But I didn't make a diagnosis of Stage-Weber syndrome in this case because his Stage-Weber is like this. You know that it is a port wine stain. So it is only stain. But you see, this is a cavernous like a manchurial. Even though the distribution is in the trigeminal region. And see other children also see all only stain will be there. So if you say like this, think of something other than that. And so the MRI was asked, but again MRI report came supporting Stage-Weber syndrome because there is some problem in the posterior region of the brain. But and MRI also was asked, which again was reported as normal. But you see, if you look carefully, you see that it is absent. That is the vertebral artery. See, and the internal carotid on that side is absent. So I am just drawing it there. So there is an arteriopathy, there is a hemangioma over the face, and the MRI which they have told us having a, see the posterior fossa abnormality. So what is it? It is faces. Okay, so think of that. And I think this is the last case. Okay, so where again, because where I have put my beginning of my career, where just after completing the DM before examination, I rejoined my pediatrics department. In the pediatrics ward, this boy was admitted for pneumonia with a diagnosis of cerebral palsy. There was a diagnosis of cerebral palsy and was attended in the pediatrics OPD. But when I sat on the floor, because at the time it was all the floor patients were there, the mother just gave me one history that the sister is affected and she is at home. And just a Tamil patient, that was the one term she used. So that gave me the proof. And so I gave this medicine. That was in 1918 I used it. And for this also I gave this. That is L-Dopa was given. That is given in the morning. We were having the class, PG classes at 11 o'clock. When 1 o'clock when I was coming, my students were telling that, sir, they were, both of them were walking in the veranda lights. So at the end, they were with me for a few, 1 or 2 years. But then because they had to give medicines continuously, so went to different places. And then they came to me after years, like this. Okay, that was in 2008. So they are grown up. One was working in a private hospital as a lift operator, but still taking, at that time he was taking 4 tablets of levodopa. So he wanted to reduce the medicine. Okay, so that was a case of Sagawa syndrome. But nowadays, when such children comes with a diagnosis of cerebral palsy earlier itself, as early as this age, you go for a gene study where the mutation is found out and the patient improves, where you can see that after the treatment and just 2 years later, now the child has improved. I think so. I'll stop here. So even though there are normal rare conditions, common conditions also has to be thought of. For example, if a child presents with acute onset visual loss, as in this case where you can see the MRI showing that finding, you do a blood pressure estimation, hypertension leading to us maybe the problem. So that simple examination, but that child also has having a renal scarring to produce a secondary hypertension. So to summarize, you know that a lot of common conditions are there in the pediatrics. This can be pediatric neurology, this can be managed by a clinical examination, but better knowledge. You acquire knowledge as much as possible, and definitely you'll be using imaging and genetic nowadays. And but be abreast with the advances in treatment in these conditions, and even our traditional disorders like cerebral palsy can be managed by the mother itself. The neuromuscular and neurometabolic treatment are also coming up. I think I have taken 54 minutes. Thank you for that.